So happy to be with you again, and I will do the second talks with a little bit different title about the current IH and narcolepsy research, etiologies, diagnosis, and medication. So to start with, hypersomnolence, as I tried to mention to you already, is very frequent condition with long sleep duration and excessive daytime sleepiness, and you can see a lot of etiologies and conditions that may be associated with obesity, others, depression, drug intake, sleep deprived, shift work, ADHD, long sleeper. So it's very frequent condition. But the only etiologies associated with severe and objectively assessed hypersomnolence disorder is NT1, NT2, IH, and KLS, but I will not report on Klein-Levin syndrome today. But unfortunately, in the ICSD-3 criteria, so our Bible for sleep domain, performed for the revision in 18 hours right now, 8 hours, sorry, is 1914. They include for sure NT1, NT2, IH, and KLS, but also hypersomnia due to a medical condition, hypersomnia associated with a psychiatric condition, insufficient sleep syndrome, and hypersomnia to a medication or a substance. What the meaning of that? How can you be sure and diagnose a medical condition hypersomnia due to? Is it really a causality or a comorbidity? And for psychiatric, it's not due to, it's associated with. They exclude that for insomnia. There is no more primary or secondary insomnia because we do not know that the causality is comorbid insomnia, but they did not apply that for hypersomnolence. Insufficient sleep syndrome, is it really central? You are just sleep deprived with consequences for sure, but it cannot be in central hypersomnolence disorder. Same for due to a medication. What is it due to a medication? It cannot be central. And what cutoff you should use for insufficient sleep? What is the sleep deprived? Is it 1 hour, 2 hours, 3 hours? It's very hard. So I do believe that we need to exclude that. And for sure, that may exist, this condition, but it could be comorbid, and comorbid to a complaint or comorbid to a disorder. So comorbid to daytime sleepiness, to hypersomnia, or comorbid to something we already define, and you can be affected with narcolepsy and depression as an example. And why not IH with depression? Is depression secondary to IH or causes IH, and not cause IH, but cause hypersomnia cannot be IH anymore. So we do not know, but we need to improve that. And I already report to you this slide, but we try to figure out and discuss this problem. So I want to come back to the three major disorders we are facing with for central hypersomnolence disorder. NT1 is MSLT. We discussed cataplexy, low orexin, or hypocretin is the same. And for IH, we discussed that in my previous talk about 0 or 1 SORM or MSLT below 8 minutes, but also long sleep duration. And there is no cataplexy, normal orexin, unrefreshing naps, sometimes spontaneous remission. And as you can see here in the middle, there is the NT2. All of the three disorders have excessive daytime sleepiness, but some of other characteristic, refreshing naps, sleep paralysis, hallucination is mostly for narcolepsy. And some, as already reported to you, unrefreshing naps, spontaneous remission may exist in NT2 and IH. So I think this illustrated where we are and where we should go, because it cannot be really distinct and individualized entity. There's a lot of overlap between symptoms and even characteristics. And of interest, the natural courses of central hypersomnolence, NT1 is very robust because of orexin loss and cannot be reversed. If you go to NT2, it can be NT1 after several years when patients develop cataplexy with orexin deficiency. It could remit. You can have no more NT2 after 5 years, as I tried to explain to you with the MSLT. And could be IH if there is just change in one SORM. 7 minutes, 1 SORM, 7 minutes, 0 SORM, not the same disease, but the same patient. So it cannot be a different disease. It's just the criteria we use which are not good. And IH is the same, could be persistent problem, could be remitted problem, and could evolve to NT2. So there are unstable conditions except NT1, and they are to be differentiated NT2 and IH with the current criteria. So how it works? I will go brief because it's a complex story, but you are awake today listening to me because of many different neurotransmitters in the brain. Norepinephrine in the locus coeruleus, serotonin in the raphe, histamine on the TMN, orexin, we discussed that already, on the hypothalamus, and also some cholinergic neurons and dopaminergic neurons as well. They are active and synthesize this neurotransmitter when you are awake. In contrast, when you're fall asleep, you are activated your VLPO, so the ventral lateral preoptic, so the anterior hypothalamus with the GABA and the galanin. This is activated region that will inhibit all the region we discussed already on neurotransmitter activated during the wake time. So this is the flip-flop model, very elegant way and very easy way to answer how it works. When you activate your orexin, you will activate this monoaminergic region in your brain and brainstem, norepinephrine, histamine, and serotonin, and that will drive you awake, and that you will inhibit your VLPO because you are awake. And if you are asleep, is because you activated your VLPO spontaneously or because of drugs, benzo, barbiturate, alcohol. You will inhibit the orexin and you will inhibit the monoaminergic in the brain, and that explains why you are asleep. So in narcolepsy, there is a loss of orexin neurons in the brain, 70,000 number of neurons in the brain. And so your flip-flop model, you are in between state because it's not stabilized, because orexin, as you can see here in green, stabilize your awake or your sleep system. So is hypersomnolence always reflecting a brain circuit dysfunction? So this is correct for NT1 with orexin deficient syndrome, the narcolepsy with cataplexy with a loss of orexin in the brain. Then you can assess with a CSF. And I have been in Australia once time only. Unfortunately, I would love to come back, and I discussed with my friend Bronstein, and he wanted to develop this assay, orexin assay, but I'm not sure that Ron did it finally. I have no idea. So this is really key to diagnose NT1. But for NT2, so patient with narcolepsy without cataplexy, the results are in between, and you cannot speculate because some will be with orexin deficiency below the 110 in red dots, but most of subjects were normal. In IH and in control, you are normal by definition. You cannot be below. If you are below, it's because you are NT1 by definition. But what about NT2? We do not know. There are some studies trying to prove that it could be a partial lesion of orexin neurons destruction, 50% of neurons, 20% of destruction of neurons. and not 95 or 98% in NT1? Is it a circadian rhythm problem that explains the high REM sleep propensity? So we did a lot of studies on that, on MCH neurons, and recently we just published all the metabolite of monoaminergic you can imagine on epinephrine, norepinephrine, dopamine, serotonin with 5 HEAA, MHPG, VMA, VMA, HVA, and there is nothing striking, unfortunately. So far, we do not identify any specific biomarker of NT2. For IH, sorry, we may speculate that there is a deficiency in the wake system or an excess in the sleep system. This is the reason why I explained to you why you are asleep, neurobiologically, or why you are awake. So we did that. Orexin, histamine, there's nothing, no differences. Some colleagues in Atlanta worked on the GABA system, David Rye, and he speculated that there is an enhancement of GABA A receptor in the CSF of patients with primary hypersomnia. We did the same job in my lab, but we find nothing. So for IH, as for NT2, there is no good biomarker. And so far, we do not know. We are still working on that a lot, and on genetics, on CSF, on metabolism, but right now, no striking results. So the last part of my talk will focus on medication, how to manage patients with IH. But first, I want to start with narcolepsy because this is most known. We do have 3 drugs to treat sleepiness: modafinil, pitolisant, solriamfetol. So Modiodad, Wakix, and Sunosi. And you need to start with that. And if it's not enough, you need to switch to methylphenidate, Ritalin, Concerta, Quasi, Medikinet, 4 different names for methylphenidate, depending on the kinetics. And after you look for cataplexy, if you need to treat cataplexy because they are problematic, and you will use different drugs if there's disturbed nighttime sleep or sleep apnea or depression. And if it's not enough, you can switch or combine, and after you can go back to sleepiness problem and to associate, if it's mandatory, drug with different mechanism of action. Pitolisant, histamine, sodium oxybate, GABA B, and most of the other are inhibitor of transporter of dopamine and or norepinephrine. So I don't want to spend too much time on narcolepsy, but it's just because the drugs we will use for IH has been well assessed in narcolepsy. And when you want to start with the first line therapy, second line, third line, what is your option? Is it because of symptoms, severity of EDS? For IH is severity of hypersomnia and sleep inertia. You cannot really compare drug studies because there is very rare, especially in IH, head-to-head comparison study, different trial, different design, different population, different dose. Safety issue is key. There is some wake-promoting agent and stimulants problem about insomnia, irritability, agitation, birth control, especially for modafinil, problem of blood pressure or subpsychiatric problem, antidepressant issue with weight gain and libido problem, Xarem about OSAS, enuresis, nausea, alcohol, and when you are taking care about kids when you are alone and you cannot wake up in the middle of the night. Take care also about comorbidities, hypertension, cardiac problem, apnea, obesity, depression. Sometimes the cost reimbursement between countries to go to individualized medicine. So safety is key because you will manage patients for years, even decades. So you need to be sure that your drug will be enough safe. So here I listed the different major consequences and safety concern. Modafinil, reducing effectiveness of contraceptive pills. You can increase blood pressure, and sometimes there is some cutaneous problem, allergic problem. For solriamfetol, the problem is mostly for blood pressure and increased heart rate with no effect, fortunately, on birth control. For the pitolisant, it may reduce the effectiveness of contraceptive pills, but is more theoretical than reality. It may increase QTC interval, but again, is mostly theoretical than reality. Sodium oxybate is it's of interest. It may decrease BMI. The high sodium intake could be an issue. 1 gram 6 for 9 gram xarem, 1 gram 6 of salt for 9 gram xarem. But there is a low XB formulation that may be of interest for this subject, and I will go detail that at the end. Amphetamine and methylphenidate, high potential for abuse with severe cardiovascular and sometimes psychiatric problem, depending on the dose. So you need to limit that to second and third line if other drugs are available in your country. So European guidelines for narcolepsy is for EDS is modafinil, pitolisant, solriamfetol. For EDS and cataplexy is sodium oxybate or pitolisant. If not, you need to combine drugs. And if the patient come to see you because of EDS, cataplexy, and DNS, disturbed nighttime sleep, you need to start with sodium oxybate. If not, you need to combine different drugs. And if it's not enough, second line, we defined these guidelines in European Journal of Neurology last year with my friends within Europe. So the reason why I focus on narcolepsy is because it will be the same drugs. And we did measure the efficacy of the drugs with a scale, the narcolepsy severity scale we just published a few years ago, as I did mention for IHSS, a specific scale for narcolepsy, proving that your drug is effective not just on sleepiness, often assessed with Epworth, but also on cataplexy, hallucination, sleep paralysis, and bad sleep at night. Second issue of key interest is the blood pressure. Unfortunately, with drug intake, you will see an increase of heart rate, systolic blood pressure, diastolic blood pressure if you use the ambulatory blood pressure monitoring. We did that for 100 and 600 subjects with NT1 following my lab before and after being medicated. We published that in Neurology. And as you can see here in green, heart rate increase of 10 as a mean of heart rate. Same issue for blood pressure. So you need to be sure and to adapt and to be cautious about the cardiovascular risk. And last year, we proposed this review, cardiovascular problem in narcolepsy, with a lot of problem because of diabetes, obesity, dyslipidemia, OSAS, PLMS, psychiatric problem, dysautonomia, and part of the game may be related to orexin deficiency, but not everything. And patients are at risk for stroke, heart failure, and infarctus. Is it the same for IH? Could be for dysautonomia, even if it's not well studied. But because of the drug effect, and we will share the same drugs to treat the patient, we can see this problem. So you need to be sure that your drug will be effective but safe. So to treat patients with IH, Unfortunately, in Europe, there is no drug approved. Worldwide, since summer 2021, there is no drug approved. There is just one drug approved in US 6 months ago. I will detail that in a minute. So we did a review with my PhD students, Elisa Evangelista, several years ago about treatment options to treat EDS in IH. So we listed all the studies, and since there is one study from Japan, Inoue in sleep medicine on modafinil. But as you can see here, they use different drugs, modafinil, amphetamine, flumazenil, clarithromycin. Some studies has been done, but mostly is not good studies, is just a short review. And this is an overview of the drugs. And unfortunately, there's very few good studies. One is from Getzmeyer in Germany. The other one is from Japan. I will show you the results. But most of the other is just, a survey, a chart review of patient follow regularly in the labs. So it's not well done compared to placebo, and they mostly look for hypersleepiness scale with improvement is very mild, sometimes 1, 2, 3 points. So it's nothing is really convincing. They use also flumazenil, clarithromycin based on this story on the GABA. But for me, nothing is really striking. Except these studies published last year in Japan with the modafinil, very known, and in yellow, they started with 16 for the Japanese hypersleepiness scale to go to 10, so 6-point decrease, but the placebo decreased 3 points. This is the reason why that chart review is not very convincing, because even the placebo decrease of 3 points. So the interest when you want to prove that a drug is effective is to compare to the placebo, not just to the baseline. And if you use the MWT, it's effective, the drugs, and nothing striking with the placebo. So modafinil works on EDS, but EDS is not enough. This is the point I want to share with you. What about sleep inertia? Sleep inertia is very challenging because patients may have difficulty to awake and to take the medication. So modafinil cannot be helpful. Sometimes they use Xyrem, I will discuss that. Sometimes they took melatonin, but there's no studies on that. What about prolonged unrefreshing daytime naps and prolonged nighttime sleep? The non-pharmacological options are not very effective. And we need better instrument to not just look for ESS, but sleep inertia and prolonged sleep duration. And I convince you hopefully to use this IHSS. And you need to regularly reassess your patient because sometimes they may remit the prognosis, the follow-up. This is key. So I want to spend time with the only big studies I'm aware of performing IH, multi-center lab. I've been involved in phase 3 studies, complex studies, 150 patient in and 115 randomized to LXB, so the low sodium oxybate, so the Xyrem, but with 92% of salt decrease and compared to the placebo. Complex study with different possibility at studying 3, very few with sodium oxybate, sometimes with stimulant, sometimes drug naive. You give the low sodium oxybate in open label study. After the patient enter in 2 weeks of stable period, and after they are randomized to placebo or to continue the drugs, and after there is a half-year extension study. Primary endpoint ESS and secondary endpoint PGI and IHSS. Primary results: decrease in the hypersleepiness scale in open titration study, And after, when you are randomized to the placebo, you go back to almost the baseline after 2 weeks. And if you continue the drugs, you are stable. Of interest for the primary endpoint, we separate male and female once nightly for the low sodium oxybate versus twice nightly. Subject with long sleep time or without long sleep time, drug naive or patient managed with alerting drugs, wake promoting agent. And it works for all of the cases, as you can see here. If you go to the PGI, it's very effective. A lot of patients are very improved with the drugs compared to the placebo. And if you go to the IHSS, it's very effective in an open label titration study that persists when you are randomized to continue the drugs, and it go back to almost normal when you go back to the placebo during the double-blind randomized withdrawal period. So it's very, very effective and of interest for IHSS that share sleep inertia, long sleep duration, and daytime sleepiness. And sleep inertia assessed as well in this study with the visual analog scale to go from 50 to 28 at the end of the stable period. If you are randomized to continue the drug, you are stable, and if you are randomized to take the placebo, you go back to the baseline at 55, based on the visual analog scale from 0 to 100. It reduces also the long sleep duration based on sleep diary. In terms of AEs, there is almost same AEs as reported in narcolepsy, so it's not very new, but it's different population, so it's of interest to assess. Nausea, headache, dizziness, anxiety, vomiting. This is the most frequent problem with sodium oxybate. There is promising drugs on the pipeline in narcolepsy, but again, it could be proposed next soon in IH. It's not yet accepted by FDA or EMA. Is the FT218 by Avadel. It's just once nightly sodium oxybate. So it's a sodium oxybate, but just once at night to avoid a patient to wake up in the middle of the night. And it works very well in a complex study of interest on MWT, on Epworth, on CGI, and on Cataplexy. So it's highly promising for patients with IH to avoid them to wake up in the middle of the night. Last slide on perspective is on orexin receptor 2 agonist. I've been very involved in this study with the TAC925 from Takeda to prove that it's really effective in wild-type mice to increase wakefulness. In narcoleptic mice, that increase as well the wakefulness. As you can see here on the right, this is the mice, very sleepy in the middle compared to the wild type. They are very sleepy and sometimes in REM sleeps, SOREM. And if you give the drug, there is almost no sleep at all. So it's very effective, and it works on orexin receptor 2 agonist, because if you remove this orexin receptor 2 agonist, there is no effectiveness of the drugs. We did that in some patients with narcolepsy, IV, and is very effective. It seems to be effective as well in NT2, so why not in IH? It is a new stimulant, very promising stimulants in NT1, NT2, and why not in IH as well. No studies on that, but just to let you know that that will exist. So to conclude, IH is one of the more severe etiology of hypersomnia. IH is different than narcolepsy. Several differential diagnoses of hypersomnolence exist for EDS versus hypersomnia. I spend a lot of time on that. Hopefully this is clear right now. Unfortunately, I work a lot on the pathophysiology and biology on IH, but we find almost nothing, no specific biomarker. There is no guidelines for the management of IH because there is little evidence-based medicine compared to narcolepsy. So there's very few studies with low-grade evidence, except the recent one published in Lancet Neurology several weeks ago. So the management should be several because several symptoms, several comorbidity. You need to educate the patient to recognize the symptoms, to fight against, and to help them with medication, to go for personalized medicine. And several drugs are effective on EDS, but only as far as I know, LXB so far is promising to treat EDS, but also long sleep duration and sleep inertia. We need to move on from Epworth to more specific scale for IH, like IHSS or other that may soon be available. I don't know, like with patient global inventory, the PRO, patient-reported outcome. And you need to take care about the follow-up because of health outcome, comorbidity, especially depression, blood pressure, BMI, and work, social, and school issue. Many thanks for your attention. This is my university, the oldest in the world for medicine. So hopefully you can come to visit my university as well. Many thanks for your attention.